Thank you. So, move to another part of our experience is the early neurorehabilitation following severe TBI, and we published 3-4 years ago a review about this importance to look at this occupation during the stay in the ICU. So if we look at the evolution of TBI patient, for example, at 1 year after the trauma, of course, there are a relationship between the severity of the initial GCS and the outcome at 1 year. For example, in gray, you have the most severe TBI patient, and the most severe are those who will die or will be into a vegetative status by comparison with moderate and with mild TBI. And in this follow-up done in Glasgow, they found half of their initial population with a disability at 1 year after the trauma. And they did again the same follow-up, but for 12 to 14 years with the same population, of course with the survivors, and they found that the percentage of disability was roughly the same 12 to 14 years after the trauma. The main sequel or disabilities after trauma are physical, cognitive, and behavioral. And if we ask the Cochrane database about the usefulness of rehabilitation after trauma, they made a strong difference between mild and moderate to severe TBI. Mild TBI, no additional specific intervention, and there are no evidence to put this patient into a program of rehabilitation. By contrast, if for moderate to severe TBI, there is evidence for benefits for formal intervention and for intensive program associated with earlier functional gain, and the question about to whether continue this rehabilitation for outpatient is still in discussion. So if you look, for example, in this large cohort of severe TBI patients, most of them were at the admission into the rehab unit they had a severe clinical presentation, and at the end of their stay in rehab unit, a small percentage of among these patients had a good or excellent outcome. And the difference between this small proportion of patients with the remaining patients occurred roughly at the 7th week after the trauma, with a gradual increase in the functional independent measure scores, going up to 50, and with progressive increase in this score. This score, for your information, the functional independence measure is a scale well admitted among the rehab world, and basically this scale rates daily activity, self-care, sphincters, mobility, cognition, communication, locomotion, and each activity is rated between 1 total assistance to 7 complete independence, and the total score ranged between 18 to 126. So basically, a patient with full or total dependence has a FIM score lower than 50. So let's go to see the factors limiting neurorehab. Specific to TBI and non-specific to TBI. Specific to TBI, of course, we cannot put our patients into a rehab program as you can see here after, for example, a cardiac surgery or after a respiratory failure. The current literature is gaining evidence into pushing this patient into earlier as possible rehabilitation to perform muscle activity and so on and so on. Our patients are more difficult to enter them into a rehab program because they are unable to communicate due to some alteration. They are unable to execute orders. They can have amnesia. They are unable to move because of spasticity or extrapyramidal rigidity, and some of them have dysphagia. It's a rare event now, but some of our patients have heterotopic ossification. That it's ossification occurring in large articulations and preventing the amplitude of the movement. And less than 10% of TBI, and probably around 0 or 0 to 5% of TBI may have such a problem. And specific to TBI is the agitation. And agitation is a frequent event in TBI patients, maybe due to the use of sedatives, but also with a change in sodium level or and so on. And you know that an agitated patient is at risk for self-extubation and removal of drains and tube, and a prolonged duration of mechanical ventilation and stay in the ICU. Unspecific to TBI is the risks for delirium, and the delirium is a very a big concern for all of them, and there are many factors associated with the occurrence of delirium, and among them the sedatives and the benzodiazepine were found in this study associated with higher risk for delirium. Another factor limiting neurorehab is the critical illness of the neuromyopathy, and especially the respiratory weakness affecting the respiratory muscles that may prevent the weaning of mechanical ventilation for the patient. So that's roughly all of the factors limiting the neurorehab in our population. So how to improve the neurorehab? In our ICU, we have to first reduce as much as possible the extent of secondary brain injury by limiting the changes in, for example, serum glucose or serum sodium, by limiting the changes in mean arterial blood pressure, by adjusting the mechanical ventilation to respect the PaCO2, and so on and so on. And to prevent systemic complication, to prevent, for example, thromboembolism and pulmonary embolism, to prevent stress-associated complication, to prevent sepsis and infection, and so on and so on. And to initiate functional recovery. So these three major principles are governing us during the care management of TBI patient. We have also to manage the cessation of sedation, and here is summarized criterion before considering the cessation of sedation: no elevation of ICP, no alteration in brain perfusion as may assessed by a transcranial Doppler, no aggravation of brain lesion with a CT scan, no cardiorespiratory failure, no seizure, and no muscle relaxant. And if you consider the cessation of sedation, and if your patient is becomes agitated, you have some therapeutic alternatives. The use of small doses of neuroleptics, for example, haloperidol. Sometimes we can use beta blockers or anticonvulsivants, and don't forget to also to use a nicotine patch in the case of heavy smoker. The DAX is not a new product, but a new product in my country. Is alpha-2 agonist, central agonist, close to clonidine. And it is very popular in general ICU because this drug was found to reduce the occurrence and the incidence of delirium, and because they also it has no effect on respiratory function. It's maybe useful to prepare and to prepare the transition between the sedation and the awakeness in our patient. But we have no data in TBI patient and small clinical case showing that this product is not very well tolerated in TBI patient. Other measures in the ICU with a chest, for example, chest physiotherapy. In our hospital, we used this small apparatus, the cough assist mechanical insufflator. Briefly, is not a non-invasive ventilation, but somehow you put a mask on the face of your patient, and the machine will increase for some seconds, few seconds, a positive pressure, and then goes to a negative pressure rapidly, and to trigger a cough reflex for the patient, and to facilitate the drainage of respiratory secretions. Is very, very useful, for example, in our patients with a tetraplegia, with a traumatic tetraplegia, unable to cough voluntarily. And also we mobilize passively the lamps, and in the case of muscle spasticity, sometimes one of our physicians will administrate botulinum toxin. We paid attention to control serum glucose and to prepare the transfer to our rehab unit to in a continuous chain of treatment. And when the patient is transferred to our post-ICU rehab unit, there are some here some criteria: no nociceptive stimulation, pain control, diagnosis of complication, for example, infections or urinary infections or heterotopic ossification. Each patient is in an isolated room with personal touch, as you can see here, and he will have sensorial stimulation and a large period of rest, because it's very important to respect his needs in terms of resting period. And here is some example: patient with gradually and progressively verticalization to providing again is proprioception and the sensation associated with standing up. Here the passive mobilization of large articulation and test to simulate his memory. And if we look at drugs being effective in these population, we have only two drugs. The first is amantadine. Amantadine is a dopamine agonist, and it was successfully used in this randomized trial done in patients with vegetative or minimal consciousness state status. And the treatment started some weeks after the trauma, and at these doses, and the treatment was done during 4 weeks. And you can see that according to the disability rating state score, that the treated group had a faster recovery than the placebo group. And if the treatment, and after the cessation of the treatment, the two groups had a comparable evolution. So amantadine is maybe a solution to facilitate the recovery for some patients. Another drug being possibly effective in this population is the use of zolpidem. Zolpidem is a drug useful to facilitate your sleep as a benzodiazepine, and it has a paradoxical property, and it was successfully used in this case with post-anoxic akinetic mutism, and with the use of zolpidem, the patient had unexpectedly good evolution with walking, with spontaneous speech, with more comprehension, and the PET scan images show that the anterior metabolism had been increased by the use of this drug. And finally, the discussion is when to start the rehab, early or delayed. And we have more evidence from the stroke patient. And if we look at the spontaneous neurological recovery, and in terms of days, weeks, months, and so on, and the program proposed to facilitate the rehabilitation of stroke patients. Within days, it's an early mobilization, and within weeks, restoring impairments, and within months, specific tasks, rehabilitation intervention, and so on and so on. So it's a program developed over a year to increase the rehab after stroke. So the question is, if for this population we have to accelerate this rehabilitation program associated with a better outcome. So in this preliminary study done in stroke patient, they found that the first mobilization within 24 hours after stroke was associated with a better outcome at 3, 6, and 2 months by comparison with the standard care. But unfortunately, when they did a large multi-center trial, they found that the proportion of a patient with favorable outcome was higher in the usual care by comparison with the very early mobilization. That means that in stroke patient, the early mobilization is not associated with a better outcome at 1 year or 6 months. We have no similar trial in TBI patient, but I found only this observational study done in Denmark, I think, comparing a cohort of patients entering into a continuous chain of treatments, meaning that after the ICU they went to a rehab unit, by comparison with the group B, with a broken chain of treatments that after ICU the patient was admitted into a surgical ward and waiting period, and before or prior to go to a rehab unit. And if we look at two scales, the outcome scale, Glasgow Outcome Scale extended 1 year after injury, and the disability rating scale 1 year after injury, the proportion of patients with a good outcome was more likely to be in the group A by comparison with the group B. So meaning that we have some indirect evidence that the earlier the program is started for TBI patients, the better they will be. So in my department, that's a picture of my city here, similar to a Greek city. In my department of anesthesia and critical care, we have 3 ICUs, neuro, cardiac, and trauma. And I have also a post-ICU rehab unit of 6 beds. And we admit in this unit a patient after severe brain injuries. At their admission, they are in total assistance. Some of them may have tracheostomy and nocturnal ventilation. And I have 1 physician, nurses, physio, speech, and occupational therapist at part-time. And for each patient, they will enter into a program of rehabilitation 1.5 hours roughly per day, 5 days a week. And they also have psychological support and dietary services. And so we are we have collected information about a large cohort of patients over 5 years follow-up. Half of our population are from trauma, and the other half of cerebrovascular accidents. As you can see, upon of their admission, most of patients had a severe dependency with daily activities and so on. And after a mean length of stay of 22 days, all of them have functional changes. In medium, they gain 70 points in the functional independent measure scale, and 11 points in another scale used in rehab. And if you calculate the delta, the changes in the FIM score by the length of stay score. It's 0.7. That means that maybe roughly every day each patient may increase by 1 point. Is a functional independent measure. And you can see that the evolution is roughly comparable for trauma and non-trauma patients. So take-home message, it's neuro-rehab unit is interdisciplinary. So the physician working in our unit is not intensivist. She's a neurologist specialized in rehabilitation. But she is in my department and not in the rehab department. We have to integrate and timely organize resource, and the prevention of complication must be done during the ICU stay. Thank you for your attention.